Good evening, colleagues. Today is that time of the day when, I really look forward to this meaty, chunky conversation about primary care. For those of you who know me, know my absolutely unbounded, unashamed love for primary care in all its glory. And I'm a firm believer that the challenges that face the NHS today. Actually, why today? The challenges that have faced the NHS for some time would be better addressed with a well positioned primary care supporting the other sectors. If we gave the power to primary care, we would genuinely have a different answer to the experiences we often have. Now, of course, for those of you who have had the pleasure of experiencing primary care in all its glory, it's the part of the NHS that is the closest to our communities. It is the part of the NHS that is so enshrined within how we as residents think we need our health services to be. And of course, where else in the world, and this is the absolute truth, where else in the world would you have a place to have an absolute heart to heart on primary care with like minded folks, but on the future of primary care webinars? So it's wonderful to see you all today evening. I am Mohit Venkatram. I'm the Deputy Chief Executive of Northeast London Foundation Trust, and I'm a doctor by background. I'm also your host for the Future of Primary Care webinars, and it is absolutely wonderful to have you all here. Northeast London Foundation Trust provides services all the way from Kent, Basildon, Brentwood, Thurrock, all the way into Havering, Waltham Forest, Redbridge, and Barking and Dagenham. It's a really, really large patch. And over the last few years, as we have been providing services, the recognition that working in partnership with our primary care colleagues has allowed us to deliver some phenomenally good outcomes for our local residents. Often the leadership of these services come from the GPs who have been working in those primary care areas for very, very long and genuinely know each patient, each family, each need in a way that allows us to provide services that are tuned to the needs of individuals. Of course, we recognize as large statutory organization, if we were able to share our resources with our primary care colleagues, together, we would provide much stronger, much better, much sharper services for the communities we serve. It's symbiotic in certain ways. So we are stronger, they are stronger, and our communities are much, much stronger and much richer for what we give together. The creation of this space, this webinar, is our commitment to invest in primary care as an organization and use our corporate resources as Northeast London Foundation Trust so that our residents, wider communities, and the population of this country benefits from better, richer, healthier services that provide the best outcomes for all of us. Of course, I have to be honest here and admit this space would be absolutely meaningless if it wasn't for the commitment we have had from all of you who have been joining us on a regular basis, month after month, and making a difference. This webinar, I remember when we started a few years ago, used to have about 30, 40 people registering for this. Now we have anywhere upwards of 250 people registering for the webinars. And by the end of the month, our YouTube hits are anywhere close to 2,000 to 5,000 hits on those. So you can imagine the passion we all share genuinely of understanding and making a difference. So thank you. Enormous, enormous thanks for helping us create this space and staying with us so that together we're making it stronger and better. Of course, like every webinar we start in the time-honored tradition, there is little justice we will do without taking a moment to celebrate the success of primary care in the period that's just gone by. NHS Digital has just published its data for February in primary care. And for a month which has slightly fewer days than the other months, primary care still delivered 29.7 million appointments across the country. That's almost 30 million appointments. That's more than 1 million appointments a day across the country. In addition to this, we also had another almost 1,970,000 appointments delivered by the primary care networks, which was on top of the 30 million I've spoken about. Now, often, many of us have read in the media the criticism that's levied against these numbers because they often say, yes, they may give appointments, but I'm not getting same day appointments. The reality is, in February alone, almost 45% of appointments, so near about half, were same day appointments that were delivered by primary care. Some phenomenal numbers. So we're talking about 500,000 appointments delivered same day for the residents, and another 500,000 appointments delivered for patients who have asked for a later appointment. Now, just under 90% of these appointments were attended by us in primary care. And that means we lost about 3 million appointments because we as patients, we as citizens, didn't fully utilize them. Because had we told them in advance, another 3 million people could have benefited from that. One of the other factors that is often spoken of is how many of these appointments were face to face. Because people have often said, well, yes, if an appointment is online, it really doesn't give me the benefit. 66% of these appointments, that's nearly 2/3. In every three of us, two of us had a face to face appointment. Now, those are some phenomenal statistics for a sector to talk about its success in 1 month. So the question then that arises is, if a sector is doing that well, if it's so well positioned to support the NHS, what can be done to further enhance their resilience? What can we do not only at local levels where trust like ours is giving a lot of importance resources, using it well so that together we become stronger, but what can be done at a national level? Because actually, the mental health sector, the acute care sector, the specialist care sector have all got dedicated support and resilience that is delivered to them nationally. So the NHS Confederation is a national NHS membership organization that develops these spaces for parts of the NHS to work together. Our guest today is Ruth Rankine. She is the Director of Primary Care at the NHS Confederation. And before I hand over to her, I mean, I have to say hats off to what she has achieved in the years she's been there. Ruth joined the NHS Confed in 2019. So for those of us who remember, that was prime pandemic period. And she was credited with setting up the space for the primary care networks to come together. And believe me, for those of you who work in the NHS and for those of you who experienced it during the pandemic, the primary care networks were the prime place where all the COVID vaccinations in this country happened. They were the leaders who led it. So today, the leader you're speaking to is the person who should be credited with making sure many of us had vaccinations on a regular basis. Of course, Ruth has held many, many important positions. She had been previous, if I remember, the Deputy Chief Inspector of Primary Care at the CQC, Director of Strategy and Planning at NHS Direct. I mean, it's one of those amazing, amazing people who has done so much across the country that we are really lucky to have her today as our guest. What really grabbed me about Ruth, though, was the fact that she was also the vice chair for Carers First, a charity for carers. And Now that brings primary care to all its glory because primary care is more than GP practices. It is so much more. It is about all the community services coming together in a very different formation. Of course, they are led by the GP practices, but the experience Ruth brings in from the community and voluntary sector, in addition to the health sector, makes it really remarkable and unique in terms of the outcomes one can look for. So before I hand over to Ruth, a couple of thoughts to share with you all. For those of you who've been on the webinar will already know there are over 250 people who have registered and are on different platforms because this is being streamed live. For those of you who'd like to post a question or have a thought, please use the Q&A button on the Zoom platform so that I can pick them up and then I can post those questions or the themes of those questions to Ruth once she's had time to share her views. Ruth, thank you so much for joining us today. It is absolutely wonderful to have you here. Shall I hand over to you now to share your thoughts for a bit on primary care and the leadership?
Thank you very much, Mohit, for that wonderful introduction. I think that you are describing someone else. I I have had a varied career, but because I love learning new things, and interestingly, if I look back on all of my career, nearly all of my jobs have been in or around primary care. So. Um, I feel very passionate about primary care. I love the people that work in primary care. I think the what we see in primary care in terms of the enthusiasm, the can-do approach, the agility, and just the desire to do the right thing for patients is the thing that keeps me going every day, and is really hard in the current climate where it's really tough in terms of money and workload. So thank you for the introduction and good evening, everybody. As Mohit says, I'm Ruth Rankin. So I work for Confed. For those of you who don't know, Confed is a membership organisation. We represent all parts of the NHS. Primary care is the newest member, albeit it was 2019. But it feels still like yesterday. And we are also a membership organisation across England, Wales, and Northern Ireland, because actually there are things that we can learn from Wales and Northern Ireland and that they can learn from us. And one of those examples is if you look at the Health Service Journal today and look at the experience of Wales in terms of integrated care boards and how that has or hasn't helped delivery of healthcare and improvement of outcomes. So there are lots to learn across the UK. Our role is a lot around influencing national policy and supporting providers to improve, providers and commissioners, and also connecting people together. Which we probably don't do enough of in the NHS. It's that thing about it's really hard to share, what's working well with others that are struggling. And I think as long as I've been in the NHS, that's been a really hard thing to do. So we do see it as a big part of our role. In terms of the primary care network, I think we've evolved in the same way that primary care has evolved. So we started in 2019 as the PCN network. And then about a year, 18 months later, actually we brought in federations into a federation network because the more we understood about PCNs, actually, the more we saw the really valuable role that federations were playing around providing that wraparound support for PCNs. And then we brought the two things together because actually we believed that there is this sort of national narrative about primary care is difficult to engage with or general practice difficult. There's so many bits, I don't know who to talk to. And what we didn't want to do is sort of perpetuate that narrative. So actually thinking about primary care more broadly, it doesn't matter what organisation you are, it's just about delivering those services at different layers of scale. Um, and since then, we have brought in other types of primary care providers. So we brought in sort of super partnerships, national providers. And then in the last sort of 8 months, really, really pleased that we've now got pharmacy providers, optometry and audiology and dentistry as well. And I think we'd always had that ambition to think about primary care in the broadest sense, because I think if general practice feels the poor relation in the NHS, I think it's nothing compared to how pharmacy, dentistry, optometry feel in relation to primary care. So we're looking forward to doing really great things with those members in terms of how we think about integration across primary care. Um, as the network, I think a big part of our role at the minute, right, is influencing the future. Everybody's talking about the 10-year plan, and so a lot of our time at the moment is spent in those national conversations, but also, sometimes there are questions posed about, well, we're not quite sure about X, Y, or Z. And it provides us an opportunity to talk to members, to look at what's happening, to think about what's working well, what isn't, and then to provide some input into the national team on some of the options. So that's taking up a lot of time at the moment, but it's really valuable. Um, and the member conversation is really important to us. So the bit of my job, and if you follow me on social media, the bit of my job I love the most is going out. So every week now, I'm kind of somewhere in the country, and I think you can have conversations with people and hear what they're doing, but it's so much better when you see it in person and you talk to a wide range of people and you see what it looks like and you see what the process is and you talk to people about what difference it's making. And those conversations are really, really powerful, and we shouldn't underestimate the value of that conversation. Because when we're then in some of the national conversations, we will be saying, well, I was in, I'm not going to name or any part of the country in case, I put a spotlight on it. But um, we'll talk about areas of the country or providers we've been to see, what they've been doing, the impact it's having. And that is having a massive impact in terms of, sort of people looking at where this is working, and looking at different models and how this could work, and connecting those national stakeholders with people out there on the ground. So that's really important part of the job. I think the second part is around growing new leaders and building up clinical leaders and non-clinical leaders. So seeing how people that have come into the network have grown in their leadership journey and are now in system roles, in trust roles, in place leader roles. So that's really important part of what we do. And I think the third bit is it's just that space to have a different conversation. So, we've always been clear that we're not the GPC and we're not the RCGP. They've got very important roles. And that's not our territory. But where we want to occupy is that space, because we are in ComFed and we've got all of the other parts of the system, is how do we make sure primary care is really connected into those other parts of the system. So facilitating those conversations between primary care and mental health, primary care and community acute, ICS. So that it's just about having a different conversation, and also just even within primary care, connecting people who feel the same, who've got the same ambition, but that's maybe not shared with their peers at a local level. So actually connecting people across the country who are thinking in the same way, and then seeing kind of what comes out of that is really, really enriching. Um, and I think so. A couple of examples, really, which starts to get into sort of, the bigger debate about the future of primary care. So last autumn, we started a piece of work with members in terms of what the future could look like, and I think it's fair to say I think it was challenging to get people to think about a different and a better future, because the pressure of today and the problems of today and the challenges of today, just I think it kind of limits people's ability to think beyond that. Um, so so it was quite challenging. Anyway, we persevered, and what we ended up doing was, rather than anything sort of at that stage visionary, we focused on actually, well, let's think about the contract, because that's the thing that people hold on to, right? It's the thing, it's all about the contract. If it's not in the contract, we're not doing it. So we kind of used the tool of the contract, to drive a conversation. So we published a report in February, which was really about, what are the sort of short-term changes we could see in, or we'd like to see in the contract, but equally, what would we like to see in the longer term? And obviously, since then, Secretary of State has committed to a whole reform of the contract. Um, and, so again, what we've done around the future, we will look to use that to influence what they look at in terms of contract reform. And another key part of that was around, we brought our primary care members together with our ICB members. So we run two sort of primary care focused groups as part of the ICS network, one for ICB directors of primary care and one for the ICB primary care partner members. And then we have a separate group, which is primary care focused, for a small number of ICB chairs and chief execs that we can tap into just specifically about primary care. And I think what was really interesting was, when we brought the sort of commissioner and provider voices together, there wasn't a lot of difference in terms of how people were thinking. Um, and because actually, on the on the whole, with a little bit of variation, what I see are directors of primary care who are really passionate about primary care, and they want to protect it and they want the best for it. Um, they're just operating in a really, really difficult climate. And I think sometimes there's this view that, it's the ICB stopping us. And actually, a lot of this, their hands are tied because of the short-term pressures around A&E performance and waiting lists. So it was really great to see that kind of alignment, of view. And within that report, which is on our website, people can read it. We talked about neighbourhood health service, because obviously it was a big topic, when we got the new government. We talked about access, obviously, because it's a big short-term priority. And then we looked at some of the enablers in terms of the funding and the workforce and the infrastructure. Um, that then led on to, but we're sort of still struggling with, but what could it look like in 10 years' time? How could this be different? Um, and it's really hard to get consensus on that, because everybody's coming at it from slightly different perspectives. So what we actually then decided to do, and it's love this kind of webinar is lovely timing, because tomorrow we will be publishing, a new report, which is sort of, we've called it Beyond the Waiting Room, the future of primary care. And it's a series of, you could call them short stories or essays, by a number of our primary care clinical leaders on their view of the future of primary care. Um, and they're coming at it from different angles. Some are very digitally focused data, some are more focused on kind of the operating model, what you do at different layers of scale, some are focused on neighborhood. But actually, I think It's about giving those people a platform and a mechanism to say, actually, this is what I believe. And I know people might shoot me down, and I know that I could be all over social media saying, absolute heresy, why are you sailing us down the river? But this is about actually just people being brave enough to say, we could do things differently. Um, and at the end of the day, the workforce isn't going to significantly increase anytime soon. The money isn't going to significantly increase anytime soon. It's how we make the best out of what we've got, at least in, the next 2 to 3 years. So we've got to be able to do things differently, in the hope that that will pay dividends in the longer term. Um, so I think there's obviously a lot of focus as well as neighbourhood health in terms of left shift, and we've published some work around looking at different options around left shift, how people are doing it, different models of care. But I think one of the key things that we've been pressing for, both from our community perspective, but also a primary perspective, is how do we know if we're achieving left shift? How do we know if we're making a difference, right? Because I'm not going to say how long I've worked in the NHS. It's a long time. And I think we've been talking about this for a long time. And we had a really good conversation with our ICB chair and chief executive group about this. And what was interesting is, some of the ICB chairs, but the problem is we're not held to account for delivering left shift, right? We're held to account for the money, we're held to account for A&E performance, we're held to account for waiting lists, but nobody is holding us to account for delivering, more cost-effective care closer to home. So actually, unless we've got something that can be measured and we can track that shift, will we ever really take this seriously? So one of the things that the asks from us that we continue to ask for is actually that in the future, if we're serious about left shift, we need a measure. We need to have a baseline and we need to have something to aim for. The question is, how do you measure it? Is it money? Is it bed days saved? Is it whatever it might be? There's different options that how much you spend, put into prevention. So there's a number of options which we're working through at the moment. But ultimately, it's how will we know, right? If we're sitting here in 3 years' time and we haven't measured it, how will we know? So that's the sort of first thing. And I think the second thing, where we kind of get to, the sort of highlight of all of this is what is the role of primary care? And when I say primary care, I'm not talking about general practice, I'm not talking about PCN, I'm talking about primary care, right? And because I think there is a massive opportunity, but and I'm a glass half full person. So when I talk to people about this massive opportunity, they look at me as if I'm like slightly mad. Because, people are tired, right? It's like, they haven't got the energy. And it's like they've seen all this before and it'll go away again if we just ignore it. And I'd like to think that actually this time we can make a difference. I really believe that we've got a Secretary of State who is committed to primary care, committed to general practice, absolutely gets the importance of continuity of care. He gets the business case. But at the same time, the money is really tight. So there's this is about protecting and valuing what patients value and what gets GPs out of bed in the morning because they think they're adding value. But equally, what can we do differently that is done, at neighborhood or at place, that actually doesn't need every practice doing it, but is helping every practice. So this isn't, and I think the risk is when we often talk about like PCNs or federations or collaboratives, practices say, well, they're going to take money from us. But actually, the whole point of this is about building a primary care infrastructure that enables us to lead the delivery of neighbourhood health, to lead and shape what a left shift care closer to home model looks like, thereby bringing more money into the whole of the sector, not actually just cutting the existing pot differently. Um, so for me, this is about like owning the future, and as I go around the country talking I use the collaborative term generically, it could be feds, it could be alliances, they could be called collaboratives, but, you know, there are some that it's just a joy to be part of the conversation, right? You've got the ICB sitting and they're like going, we're absolutely behind this, we're supporting you to do this. You've got primary care, you've got pharmacy opt-on depth in. Yeah, actually, we don't want to just be a voice. We want to be ambitious. We want to be a delivery vehicle for left shift. We want to help deliver and design and deliver neighbourhood health. Um, and then I go into other areas and they go, nothing to do with us. We just want to keep delivering for our patients in our practice, and that's fine. But at the end of the day, it's about seeing the opportunity and then saying, okay, I don't want to be part of that. I'm happy for you guys to crack on, but I want to just keep doing what I do in my own practice. So I think there are massive opportunities. And then in the work that we've done on neighbourhood health, we've worked with an organisation called Local Trust, which is a charity which gives grants to local communities to support community regeneration. And we're doing some action research sites at the moment where we're bringing NHS and voluntary sector together to really think about how they work together to improve health outcomes through the more social aspect of it as opposed to the NHS. And I think we have failed if we deliver a neighbourhood health service that is only about what the NHS is responsible for. And we haven't thought about our communities, the assets that are in our communities, and the role of local authorities and the voluntary sector in supporting that. And sometimes I'll talk to acute chief execs about neighbourhood health, and they'll say to me, "That's all lovely, Ruth, but how's it going to reduce my A&E attendances?" And I think we've got to stop sort of thinking about what's the solution to the problem, but start thinking about what are the symptoms of the problem. Because if we don't, we're just on the hamster wheel, right? And we'll be sitting here in 20 years again having the same conversation. So I think there's massive opportunity. There's for primary care working at scale, working at a place level as a provider, as a legal entity. It doesn't have to be primary care on its own. In Birmingham Solihull, for example, they're working primary community mental health, social care in a collaborative at system devolved to localities. We've got in Portsmouth, they've got a citywide partnership with PCNs, local authority, acute community. In Herefordshire, it's just a GP collaborative, but that's where they've started, and they're starting to bring in wider primary care. So I think there's some great federations, great collaboratives, great alliances. You have one on your patch. Mohit, I know that Craig is listening this evening, and they're just doing like really great work in terms of supporting general practice, taking some of just the heavy lifting of practices, doing some of the more strategic thinking in terms of a neighbourhood, but also in many areas, being commissioned by the acute trust to deliver services on their behalf. So we've got models out there, like let's not reinvent the wheel, let's build on what's working, but be really ambitious about what the future could look like.
I think it's phenomenal what you shared and your thoughts, and you're spot on. We are quite fortunate, actually. I could name about five or six organizations on our patch that are doing an absolutely amazing job, and without a doubt, Craig's one of them. Absolutely no doubts about it. I think the ability at your level to influence policy is crucial because while you can do some wonderful things at local place levels, actually the ability to change completely the political direction in which the investment comes in gives a very different focus. And there are quite a few questions on that route. So I'm going to start with the very first one, which is really around
Can I
trying.
just, before you go, sorry, before you go to
Yeah,
the question, so yes, and right, a lot of the way in which we influence is based on what we know our members are doing, right?
yeah, yeah,
So, we will have a view. We've got a policy team, right, who, they're like just they're brilliant policy people, they look at the evidence, they come up with the options. But for me, it's got to be grounded in reality, right? And the
absolutely.
reality comes from our members. And that's either talking to our members or actually going out and saying, okay, well, if we were to do this, what would that feel like? How would that play out? So, and when I was a civil servant in the department, I remember my boss at the time, who is now an ICB chief executive, who I'm not going to name, um, but I was setting up walk-in centres, right? It was 1999. I was leading walk-in centres. GPs hated them because they were nurse-led. But the target was to set up 20. We set up 41 within 12 months. We had loads of money, right? And that's the difference to now. Then we could do transformation because we could run services and build the future. Now we've got to do both with the same pot of money. But I remember my boss saying to me, Ruth, I think you're too operationally involved for a policy person. And I said, but how do I develop good policy and understand how it needs to change if I don't see how it's working on the ground, the good and the bad? So our job is, yes, to influence, but the power of and our ability to do that comes from what our members are doing.
Absolutely. And I think I would agree with that. The challenge, though, is many of our primary care practices, many, if not all, are so besieged by the here and now. Sometimes the ability to lift your head up and see a future that doesn't exist, is not enshrined in what's today's roots, is really hard. So,
Yeah,
quite often, policy can't just take into account the here and now. It's also got to start helping them vision a future that may not be anything like this. And it'll be much better because the outcome. I have never met a GP. I have to say, I don't know how many thousands of GPs I have met in my life. I have never met a GP. In fact, I've never met a clinician who doesn't get up in the morning and think, I want to do a great job today and make a difference to someone. I've never met one.
yeah,
But I think we're so caught up in doing the here and now and the daily, what we are used to doing, that you get up and do exactly the same thing that you did yesterday, hoping for a different result. And that never happens because you get the same result for the same action you're taking.
yeah,
And I'm going to lead us on to something slightly different because there's a wonderful question around influencing the voluntary and community sector role in this primary care space because it plays a rather crucial role. And the question that's put around is around one set of voluntary and community sector activities, hidden disabilities people, but actually the carer's role is so much wider. And in today's world of money being tighter than it is, often one sees some transactional decisions being made that are not grounded within the strategy of what's right in the long term. How do you see the role of the NHS conflict at this time to be able to rethink how people continue to think around the policy decision of investment in community voluntary sector as a co-participant in what the primary care is, rather than let's just invest in primary care. Because actually, all the work that happens with people who are now working in different ways in primary, like social prescribing, it puts it in a very different space. What's your view on that, Ruth?
This is it's a live conversation that we're having at the moment, because I think that in the same way people say, it's really difficult to engage with general practice. I think mostly that's an excuse to not engage with general practice, right? But I think we in health would probably say it's like quite at our level, it's quite difficult. Who do I talk to about this? And um, so we have been talking about actually, whether or not we can build a sort of a coalition around health, local authority, voluntary sector that can kind of operate at a national level in terms of just making sure that we've got the right input into the right policies. And of course, this is cross government, because one of the things Matthew Taylor, our chief exec, talks about a lot is, this isn't just about neighborhood health. This is about public service reform,
Yeah.
okay, across government, of which health is a part. And we've talked a lot about actually health and all policies. Um, so I think we haven't, I think the short answer, Moe, is we're still working on it, right? But certainly in everything that we have developed and produced so far in neighborhood health, it comes very much through that community lens. Again, when you go out and do some of the visits, sometimes it's easy sitting and you go, oh yeah, that's lovely. It's lovely. It feels a bit fluffy. And when you go and see it on the ground and see the impact that a really simple, cost-effective intervention can have that doesn't need any sort of healthcare professional. Like, it's amazing. And the work we were doing with local trust, they give an example where in one area, the GP practice noticed like every Wednesday morning, the waiting room seemed to be full of like sort of 80-year-old ladies. And they would all just sit and have a chat, and they'd all booked appointments. So anyway, after some obviously diagnosis, they came to meet there. It was everything else in their community had disappeared, right? The cafes had shut, the clubs had shut, the pubs had shut. There was just nowhere for them. So they used to book a GP appointment and come and meet in the practice. And through the work that local trust did, actually they gave them a grant for a tiny amount of money, and they found somewhere for them to meet and just have coffee every Wednesday morning.
What a phenomenal example. What an
So
absolute, and
it's
that's the
not
reality.
expensive, but it's
Yeah.
got immediate impact on GP demand.
Absolutely, absolutely. And it's such a nice way of giving power back to the community. Because really what we would have done in the NHS had we done this is done a risk assessment, had someone who had done a health safety check, a security manager would have come in, someone to open the keys, a duplicate set of keys would be made, a policy would be written. 7 years later, we would open up a new building, all with good intentions. I have never met a clinician who doesn't want, but our processes and systems and cost of it would have been nowhere close to that little bit of grant and the people running it themselves. And the power they hold by doing it is so much better because they just grow the club, more people join. What a lovely example. I think there's another thing that's coming on, and Ruth, for those of us who have been in the NHS for ages, I mean, there are these buzzwords that come, and you often think, isn't that Emperor's New Clothes exactly? And the neighborhood, and there's a question also posted by someone around, isn't this just something that used to already exist and now is a new term? And it is there, and is it really a new concept? Now, personally, I have a view about it, but clearly you are the person who people want to know from. What's your view about that?
Um, so I remember when it started, we started talking about a neighborhood health service, and And I thought, so you start to read a bit, and I thought, isn't this what we used to call just MDTs? Um, and and of course you try not to be cynical and you try to be positive. Um, so I think I think there's a lot that we can learn from really good MDT working. And I think those of us who have been in the NHS for a long time, redesigning service, delivering new ways of working, will have done this in some form, right? I think what's different about this time, and it's big if we get it right, is it's not just about health. So I think we pay lip service to the responsibility of local authorities or voluntary sector. I think this time, if we get it right, we've got to actually embed that model in terms of truly cross sector, so outside of the NHS as well as inside of the NHS. And there is a risk that, and you can see it coming, right? When you read things about neighborhoods, it's like, oh, well, that's the PCN boundary, or that's this boundary, or it has to be around this trust. And, and I get it as a natural control freak, right? I get it because you can measure it and you can see it and you can draw it. And and by giving clear guidance, you can control it. And that's my natural instinct. But I guess from what I've seen working, with the sort of local trust on the community side, is actually there is so much more value from that bottom up, slightly loose approach in terms of giving value back to communities about how they feel about themselves, giving them back power, giving them back control in terms of actually a lot of this is within your gift to manage your health and well-being, and this is how we can support you. But just empowering people, which then obviously means, the NHS response, the local authority response can be less. But I think it's got to start where, we talk about redesigning healthcare, and we always say, it's got to start with self-care and self-management. So why should this be any different? Why should this not be about, how do we empower people to look after themselves? And when Mark Spencer in Fleetwood is the obvious example. They've got like 122 local groups, all run by volunteers, that respond to what need have we identified in this community? Okay, let's set up a group, whether it's men's walking football or, dramatic, drama or art, and they have a tiny bit of money to, provide a cup of tea and a chat. And it's just, I think there's a risk because of the short-term pressures to demonstrate progress that we will lose sight of the bigger picture and the bigger win.
I think you make a really good point, Ruth, a really good point. I mean, personally, I agree with you that there's something around, there are aspects of what's being propositioned, which are stuff that's been around. But the good thing about neighborhood is also taking into account the wider things you spoke about. It's talking about the community and voluntary sector. It's talking about the people power. It's talking about what should we not be doing because actually we are disempowering people from doing those things. I still find it weird in today's world that there are nurses who give insulin injections. I mean, at home you do it with families and carers and friends. It's a waste of an NHS resource and it's our public money. All of us put it into that. We might as well use it for something else. And I think it's really good how you put it out to say, yes, there are aspects that are new, but there are aspects that are different in what's being spoken of now at all. And I think there are loads that people are, so there are questions around your views on social prescribing. And I think what started as a model of social prescribing is very different from where social prescribing is today.
So I think this, so I personally, I think if it's done well, it's it's like everything. If it's done well, right, it can have a massive impact. I know generally around the R's roles, there is a lot of conversation about have they added any value. And actually, I think some of the roles, if you think about social prescribers particularly, um, what they have done is uncovered need that was not being met and that would end up in a worse situation much further down the line and therefore cost more. Um, and I was talking to one of the mental health voluntary providers a few weeks ago, and we were talking about, working with the voluntary sector and like how do you identify the kind of the high risk people in our services? And she said to me, but Ruth, she said, there is a massive proportion of people that do not present to statutory services. They turn up in the voluntary sector because they don't want to get into that system. And they feel, this is more responsive and it just feels less like a big brother type response to their need. So I think, we have to recognize that there is need out there that isn't presenting for whatever reason. So again, it comes back to the need to work with voluntary and other providers because they are managing a lot of this. And so I think that, the roles that are around helping people to find the help they need, because we know how difficult it is to navigate the service and we work in it. So for me, it's that and sort of care coordination is really important.
I think that was a really telling line, which you said around the challenge of navigating a system despite working in it. I mean, I have to say, um, my experience as a patient in the health service has been quite an eye-opener. You
Mm.
recognize I have found absolutely everyone was compassionate, kind, considerate, helpful, but my God, it's a complex system that we have developed. It is so hard. And if someone like me who spent 33 years being a doctor, I've struggled with it, what's it for a common man who walks in? They must think, my God, what is this about? So I think you're spot on when you talk about the complexity which we weaved in. And I think that there's a question around we are moving towards out of hospital agenda. There's a lot of talk about, but there is going to be no growth in workforce. And will there be any investment in virtual wards or similar ideas? I think that's questionable. What's your view about the change that is needed to really make a difference to where the NHS is headed?
Um, I think it starts with leadership and mindset. Um, I think to you've got to have a group of people who really believe, the right thing to do is for care to move closer to home, irrespective of the consequences for their organization. Um, because, there will always be jobs for people. They just might look slightly different or be in slightly different settings. Um, and I worry at the minute that particularly, and people will have heard me say this before, I feel as the money gets tighter, um, collaboration gets harder because everybody's protecting their own. And I think that applies to clinical workforce as much as non-clinical workforce. So I think that if you've got the right leadership who believes, in what we're trying to do, irrespective of the consequences for the organization, and you build the right relationships, and I think you apply this to anything, right? It's like as if you've got a clear vision, so you all know where you're going, and you've got the right relationships, kind of taking that forward. I honestly think you're that's one of the hardest things because I think the rest, in terms of you can change the commissioning arrangements, you can change the payment mechanisms, you can think more innovatively about estates because if you've got the right mindset and the right relationships, you have a can-do approach.
I think you're spot on, Ruth. And given you are the national leader for primary care, you are the director at the Confed, the membership body that makes all the difference. Very short form of words. What do you see as primary care in your portfolio? How do you define primary care?
At the minute, um, it it's it's the four professions of primary care: general practice, pharmacy, optom, dentistry. I think where it's moving to is, I think, people will be talking about out of hospital care, right? I think there is there is definitely scope for better working or joined up working between primary and community services. Um, and I think that there is massive opportunity in that intermediate space. If you think about how do we reduce waiting lists, how do we avoid admissions, that sort of step up, step down space. GPs with a special interest, if we're talking about frailty, working with community geriatricians, working, bringing consultants out of acute. So I think there is a lot of potential in that intermediate space. And but I mean, we've done that before. This isn't new. We've done it before. Um, so I think there is a bigger future. But I think we've kind of got enough to do at the minute, just trying to get primary care working in in a joined up way within primary care and within the system. Um, and it will involve taking some risks, and that's always a challenge. But I do believe out there, every day I see there are a lot of primary care leaders who know how to do this and who've got the vision. And I think hopefully with the new sort of structural arrangements and a 10-year plan and a Secretary of State who wants to devolve more to um, local responsibility and accountability, then there will be more opportunity actually for primary care to lead.
I think you know how it is, Ruth, when you're having fun, time flies and you don't even realize. And suddenly I looked up and it was almost the witching hour. So, and there are so many questions, some really interesting questions around the complexity of the new changes in primary care, the triage process. But those are questions that we will definitely be tackling with more speakers who come along on the line of sharing their views, sharing their expertise,
Who
looking at the
hopefully will be more knowledgeable about the intricacies of online
and
triage than me.
Indeed, and that's one of the reasons I didn't pose that question at all towards you because your role is very different to having those level of details, and I completely appreciate. But it has been absolutely wonderfully heartwarming because the extent of effort you're putting in to address this support, going out yourself, visiting practices, and then at a national level being able to influence and create that support for primary care. um, I mean, it is just wonderful to hear that. Now, clearly, one has to recognize mental health, community sector, acute sector have had this support for years before they have come to the place they are in. So we will require sustained effort going forward for primary care to ensure
Yeah,
that they
no,
can also.
yeah, absolutely. We have expected primary care to change with no leadership programs, no OD programs, and that's got to change. So this is as much about the underpinning support and improvement that expertise that's needed around primary care as it is about, what the future model of care looks like. But, listen, we are on a journey, and there is so much to do, and so much that we want to do, so many opportunities. And as I say, the days where it feels like a real slog and you'd feel you're not getting anywhere or making a difference, you just you go out and you talk to a member, and actually it keeps you going.
It
So
does, it does. And it's rather heartwarming because some of the innovation that people are doing despite the challenges is
yeah,
really delightful to watch. It is really delightful. And it feels like we're putting our money where the intent is with the new Secretary of State making some very, very positive noises around his views on what will be the neighborhood. So it is really wonderful to see the outcome that our residents will face. And there were some gems I heard tonight from you. I loved the bit about trying to connect primary care to the other parts of the system. I absolutely loved it because that's where the strength of primary care comes in, to be the compare across the different parts of the
yeah,
system and to manage that comparing. I think I absolutely loved the conversation around using the tools of the contract, but not getting stuck on funding alone, looking at the enablers that are there to make it easier for GPs, for primary care professionals to do the right thing for our residents. Clearly, the left shift is a piece of work that will evolve over time because we'll need the evidence. We'll have to be able to prove, we'll have to use QI as a methodology to try and understand what's the evidence behind that left shift. But what was really, really heartwarming to hear was when you used the term, what would the patients value? And that's why we are all here there today, not for primary care, not for secondary care, not for specialist care. Together, we are here for our communities and to make that difference. So I can't thank you enough. I'm sure my colleagues online, the 200 odd people who registered, would have without a doubt picked up more nuggets than I have. But thank you so much for making this such a wonderful evening, Ruth. It has been just delightful. And colleagues, for many of you who are going to be celebrating Easter, Passover over the weekend, I hope you have an absolutely phenomenal time with your families. Enjoy that time with them and have a great time. I'd also like to thank Holly and Harry, who in the background just make this such a polished, nice, slick effort. Believe me, if I was left alone to do the digital work, it would be an absolute mess. So thank you, Holly and Harry, for making this all happen. Thank you all for joining us. Next month, our guest will be Dr. Johnny Marshall from the National Association of Primary Care. So please use the QR code to give your feedback to us. It is really crucial. It allows us to make sure we are doing the things that you would like us to do and asking the questions you'd like us to answer. Please also use the second QR code to register for the next webinar with Dr. Johnny Marshall, which will be again in May. I hope you all have an absolutely amazing bank holiday. And Ruth, thank you so much for joining us.